So good evening, ladies and gentlemen. We are back again with another exciting evening of No Thrombosis Workshop Series. I am Dr. Neha Jain, and I welcome you all on behalf of Emcure Pharmaceuticals Limited to this wonderful event today. We as all understand that stroke is a medical emergency, and a stroke is not only limited to the patient who gets it, but it has its impact on the entire family. We at Emcure understand this medical emergency and are committed to the same. So we think that this is the right time to reach out to our experts and understand best on how to look for a better way forward in managing this clinical condition. We are very privileged and fortunate to have with us the expert neurologist of the country guiding us in this education initiative. It's my honor to welcome our expert neurologist today. I first take pride in welcoming our course director, Dr. Subhash Kaul sir. Dr. Kaul sir is a senior consultant and stroke specialist at KIMS Secunderabad and a chairman of KIMS Foundation and Research Center. Sir has been a faculty for over 27 years at Nizam's Institute of Medical Sciences, Hyderabad, and also the former professor and head of Department of Neurology and Dean at NIMS. Sir is a principal investigator and co-investigator in several national and international projects, including the largest single center Hyderabad Stroke Registry funded by ICMR. Sir has been the president of AP Neuroscientist Association and of president of Indian Stroke Association and president of Indian Academy of Neurology in the past. He has been honored with the State Teacher Award by Telangana government in 2017. I now take pride in welcoming our moderators for the program today. Our first moderator is Dr. S. Meenakshi Sundaram sir. Dr. Sundaram is a senior consultant neurologist at Apollo Hospitals, Madurai. Sir brings with himself a rich experience of over 2 decades. Sir is a principal investigator for many international trials such as refractory partial epilepsy trial, stroke, acute stroke intervention trial, and Parkinson's disease trial. Sir is also the editor of South Asian edition of the Book of Practical Neurology by Jose Biller, Walter Coover in December 2020, and has also contributed to many books on neurology. Sir has also presented papers at various prestigious national and international forums and is a recipient of Best Research Paper Award at 10th Annual Conference of Indian Academy of Neurology at Lucknow in 2002. I now welcome our second moderator, Dr. Rahul Bhaviskar sir. Dr. Bhaviskar is a senior consultant neurologist at Sahyadri Super Speciality Hospital, Nashik. He is the recipient of Prabhakar Sandle Memorial Gold Medal for standing first in MD medicine students. He is a principal investigator for many clinical trials involving epilepsy, stroke, Parkinson's disease, and multiple sclerosis. He is also attached to Dr. V.N. Pawar Medical College for their medicines department, and he holds very special interest in the management of headache, epilepsy, stroke, dementia, and MS. I now take pride in introducing our expert speakers today. Our first speaker is Dr. Pramod Dhonde. Dr. Pramod is a consultant neurologist at Nanded Dhonde Hospital and Shivansh Neuro Rehabilitation Center at Nanded. He was also the assistant professor at JJ Hospital, Mumbai in 2012-13. He has presented papers and posters at various national and international conferences, including the prestigious Tournament of Minds at WCN Kyoto in 2016. He also contributed as co-author in various national publications, for example, COVID-19 mucormyosis, stroke, and CVST. We are very honored to also share that he is working in neurorehabilitation field and has also started a highly advanced Shivansh Neurorehabilitation Center at Nanded. He'll be presenting an interesting case of central retinal artery occlusion thrombolysis. I now welcome our second speaker, Dr. Veda Nayagam sir. Dr. Veda Nayagam is a consultant neurologist at Kongunad Hospitals, Coimbatore. He was a former assistant neurologist at Sri Ramakrishna Hospital, Coimbatore, and he has presented over 4 papers in reputed journals across country and worldwide. He'll be presenting the interesting cases of stroke thrombolysis special situations. With this brief round of introduction, I once again welcome and thank you all my dear faculty member for being here with us today. I would now request our course director, Dr. Subhash Kaul sir, to kindly give us a brief overview of the program.
Yeah, Neha, thank you very much. I think you set up a very good introduction. I must again thank Emcure company for making this possible to have month after month this session of difficult cases, interesting cases, cases from which we learn. When we have these indications and guidelines, they are based on clinical trials. And clinical trials are done in a very controlled, safe environment. But the real world is not like that. Real world is different, in which we get difficult situations, contraindications exist, and yet we have to take a decision. So we have to constantly balance between the risk and benefit, inform the patient, and then take a shared decision. I remember when TPA thrombolysis, which was the first thrombolytic, came 25 years ago, there were very limited indications. Most of them were contraindications. And as time went on and went on and went on, today hardly there are any absolute contraindications. Now there are only relative contraindications. And even in those relative contraindications, the physician has to take a call. So therefore, we always learn from experience, we learn from each other. And I was seeing today's program includes such situations which are uncommon, which are difficult, and which are off-label, if we may say so. So once again, I welcome our moderators and Meenakshi Sundaram, a dear friend, and other moderators also, and our speakers tonight. And with that, I hand over to, I think, Meenakshi Sundaram. You please take it over from here, Meenakshi.
So you're muted.
Namaste, sir. Thank you for guiding us always, sir. Thank you, sir. Without ado, I think we can take it for the speakers, madam. Thank you very much, sir.
We would request Dr. Pramod to please present his case. You can share the screen.
Am I audible now?
Yeah, you are audible.
Yes.
Yeah. And my screen is visible also.
No, we can't see your screen, Dr. Donde. You might just try sharing it again.
1 minute. Is it now?
Yeah, it's a blank. We see a blank screen, as in something is shared, but we can't see.
1 minute. Is it now?
Yeah, you can just make it full screen. Yeah.
Yeah.
Yeah, done.
Okay, fine. Right.
Visible, sir.
Yeah, thank you.
Visible, you can just full screen, sir. Yeah.
Yeah.
Completely fine, sir.
Yeah. At the outset, I would like to thank Emcure and our respected moderators for giving me the opportunity to present this case. And this is one of the case which I think I have thrombolized first in my lifetime, and many of them might have done it earlier, but there are very rare cases to be thrombolized in this manner. So this is a case of a vision restored in a filmmaker. He is a young assistant film director around 30 years old, working from home due to COVID restrictions in Nanded. And he was just having some fun at his farmhouse, and he was suddenly felt that he was an occasional smoker, non-diabetic and non-hypertensive. He was having presented with the history of sudden onset left-sided visual impairment starting in the upper field, followed by the significant visual impairment affecting the whole field over the period of almost 10 minutes only. So he was known to one of the ophthalmologists, so Dr. Mane, nearby my hospital only, and he consulted his ophthalmologist within half an hour, where he could diagnose clearly that it is a complete retinal artery occlusion, where he could see the pale retina and very sluggish flow in the retinal artery with no PL and no PR during that when he reached at his hospital. He has been given ocular massage, but unfortunately he could not take a photo because he was in a hurry. He knows that these patients could be thrombolized and our hospital is nearby. So he called me up that I'm sending a patient of this central retinal artery occlusion. Could you thrombolize him? So in this patient, there was no headache, fever or similar illness in the past. So referred to us for the thrombolysis, and after ruling out contraindications with strong informed consent, he was given tenectase, and around dose was 16 milligram with equivalent of 0.25 milligram per kg at 1.5 hour. And initially after giving tenectase, he had headache lasting for 1 hour post tenectase, and his vision, we were very surprised that his vision restored to hand movement after 6 hours and to finger counting at 6 months the next day, and on day 3 it was near normalized. So that was a magic that has been done with this drug in this patient of complete central retinal artery occlusion. And he could just I'm just giving the artistic diagram. In the first, we are seeing there is pale retina all over. There is some mild cherry red spot was seen as shown by this our ophthalmologist, as he could not have the photo, so he just shown the artistic diagram. This was the from book actually. So this is the central there is pale retina, and you can see the cherry red spot in the over the macula. Actually, cherry red spot, what we are seeing is actually an optical illusion. Optical illusion means if you see the retina is pale and this red spot, there is no macula. Macula has got less nerve fiber, so it stands out from the background of the pale retina. So it is called as a cherry red spot. So it's not actually cherry red; it's a pale retina that is giving a look of cherry red spot. And this is the actual photo of his retina on almost day 6 it has been done. Day 3 it has been done fundus photography, and it was showing almost clear normal fundus of this patient who have been thrombolized with tenectase. So on evaluation, his carotid Doppler was normal, 2D echo was normal. He was having dyslipidemia with normal this blood sugar level. His CT brain was done after thrombolysis. As we were in a hurry to save the eye, actually I could say it was a mistake from our side. It should not have been done, because we should have done ECT prior to this thrombolysis. But we thought that what could be the abnormality. I will just discuss this issue in later question part. And it was luckily normal for us, because there were no complications happened in this patient after thrombolysis. So questions from this case, which I found that this could be relevant, that many of the times these public or ophthalmologists don't know this CRI or thrombolysis. Ophthalmologists, though they know that they still go on doing this ocular massage, and there are therapies which are not very convincing and not proven, not having much of benefit, and they do waste the time during this period. As far as this ophthalmologist, Dr. Mane, is concerned, he was very vigilant in sending this patient so that he knows the thrombolysis. I think ophthalmologists, particularly, and public also, to be made aware of this thrombolysis more often for CRAO, so that these patients could reach early towards us. Then what is the best imaging modality to do before, or is it necessary to do avoid delay? That is also one question. Suppose we have 100 patients of CRAO, supposedly I'm telling you CRAO, where if you do the CT to avoid time delay, if you do a CT after thrombolysis, what will be the harm? Are there any chances that he will have some aneurysm or something, some subdural hemorrhage or something kind of things that are very rare to find on a normal patient? So is it really necessary to do a imaging prior to also in these patients of CRO? That is also one question which is still unanswered. Then TPA versus tenectase, whether we should give TPA or whether we should give tenectase, that is also an issue which can come up after this case. So I will just try to have a brief paper on this discussion about this. This is one of the very beautiful paper by Valerie Bowsey and Nancy Newman from Journal of Neuro-Ophthalmology, Thrombolysis for Central Retinal Occlusion, Time is Vision. So they have took the meta-analysis of various cases and case reports and case series from this up till 2020, and there were around 111 patients. They have been seen that they have gone under thrombolysis, and the most common cause of non-arthritic CRO is proximal embolus deriving from the ipsilateral carotid artery, aortic arch, or heart. Embolus composition is variable. The platelet fibrin cholesterol emboli originating from the carotid arch, heart walls, or the aortic arch being encountered most frequently, followed by thrombotic emboli related to AF, and rarely calcified emboli originating from the calcified cardiac walls. And I will just give you this brief retinal artery anatomy. If you see this figure, there is this central retinal artery which reaches this lateral part of the optic nerve, almost 10 millimeter behind the optic nerve, and it goes inside the optic nerve head, and it gives in a centrifugal direction. So, and there are these short posterior ciliary arteries which supply this optic nerve head, and they go from this centrifugal distribution. Centrifugal means they are going into the centripetal distribution. So whenever we see this anterior ischemic optic neuropathy, we see this involvement of the ciliary arteries, which gives an altitudinal field defect, and which is little bit more common than this CRAO. So whenever this CRAO happens, it is mostly embolic, and anterior ischemic optic neuropathy happens, it is more of this hypoperfusion or some atherosclerotic risk factors are there. It is not, it is never embolic, as it is affecting this short posterior ciliary arteries. So this is one of the concept which is has been shown in this article, that is the retinal penumbra timing, which is a little bit different from this cerebral timing. And this preclinical animal studies in rhesus monkeys indicate that the irreversible damage to the retina from ischemia likely occurs in less than 240 minutes from the onset of experimental CRAO. Now, retinal thickness measured using OCT may be used to quantify retinal edema and acute CRAO, which correlates with the time elapsed since retinal ischemia onset. Despite lack of definitive data on human retinal penumbra timing by analogy with this cerebral ischemia affecting small end arteries, it is likely that thrombolytic administration up to 4.5 hours, as we give in stroke, has to be from symptom onset, will help retinal reperfusion. So there are these various studies now which includes both this intravenous thrombolysis as well as intra-arterial thrombolysis. So there are various case series, like first from 1995 from USA, where 2 case reports are where there TPA dose was not mentioned, and one patient improved, both patients improved, there were no complications. So you can go this various articles from intravenous and intra-arterial thrombolysis, where they have seen that intravenous thrombolysis is relatively better. And better means it is effective in whichever the selected patients they have chosen. And this is another thing which has been shown, that intra-arterial thrombolysis is central retinal artery occlusion, because these arteries, ophthalmic arteries, are very small in diameter. So it has to be microcatheterized, and we have to give the thrombolytic agent through these ophthalmic arteries. So it needs an expertise. I think it's very, very difficult to get this kind of expertise for this intra-arterial thrombolysis. But there are case series which has been shown that intra-arterial thrombolysis is also effective. But they have given in this 2 forms, either in an infusion, continuous infusion, or anticoats, means they are given some small dose of TPA, and after that 5 minutes again it is repeating if it is not showing improvement. These kind of 2 methods of administration has been described with the intra-arterial thrombolysis. I will not go into the details of this one. So the protocol has been given as like that: if it is acute monocular painless visual loss, presumed acute non-arthritic CRAO, then eye stroke code activation, history, visual arm symptoms, onset, time and tempo, last known well systemic symptoms suggestive of giant cell arthritis are there, it has to be excluded. Other neurological symptoms, current medication list and allergies, recent surgery or recent bleeding, and past medical history, ophthalmological evaluation, visual acuity, pupillary examination, anterior segment and dilated fundoscopic examination. If possible, patient in eye clinic fundus photograph and macular OCT before transfer to ED or stroke center. And acute non-arthritic CRAO, what has to be done? NIHSS and modified Rankin score. That neurological examination is obviously not necessary in this patient, but still if it is there, already some deficit is there, we should do this. Place this anticubital intravenous lines, then these laboratory parameters has to be done. Echo, this electrocardiogram, non-contrast CT before TPA, CT angiogram head and neck. After TPA, if applicable, you should not delay the TPA. And same kind of thing which we do in stroke patients. Time since visual loss onset or patient's last known well, if it is less than 4.5 hours, no IV altiplase contraindication. IV altiplase as has been given in stroke, that has to be administered. IV altiplase exclusion criteria identified, or patient declines IV altiplase, then activate local neuro intervention team, transfer patient for IAT. And if 4.5 to 6 hours, then we can consider for more than 6 or 4.5 to 6 hours, we can consider to giving this one eye thrombolysis. And if it is more than 6 hours, aspirin plus clopidogrel. So this is the protocol which has been given by this Nancy Newman and Valerie Bauzy. There is this when the CRAO thrombolysis comes up, whether patient will accept, patient's relatives or patient will accept or not, that is the one question. They have this survey which has been done for this. A 1996 survey preparing patient preference for the treatment of CRAO showed that 39% of the surveyed adults would accept some risk of stroke, and 37% would accept some risk even of death to triple the chances of recovering 20 by 100 in one eye when unaffected eye is sighted. More than 80% of persons would accept this risk if unaffected eye is not sighted. So we are lacking in giving this kind of information to the patients, that we should do this kind of survey in India also, because CRAO thrombolysis is rarely done. There are patients, but they hardly reach to this proper center during time. So what about now tenectase? Tenectase, a newer thrombolytic agent, has advantage of easier administration than alteplase by using single IV bolus, higher fibrin specificity, and longer half-life. A recent meta-analysis demonstrated evidence of non-inferior to alteplase, leading to a level evidence of 2B for tenectase in select patients with brain infarct, such as those eligible for mechanical thrombectomy or with minor neurological deficit impairment and no proximal large vessel occlusion. In the absence of tenectase approval by FDA in cerebral ischemia as of yet, scientific reports of its efficacy in safety in specific endorsements cannot be currently made in this regard. So in CRAO, they are still skeptical about giving tenectase in CRAO, but I think whenever we are using as per the stroke protocol, so I use this tenectase because we have approval for this tenectase in stroke, and as CRAO is one of this ischemic event, so we think that we will not be medical legally liable for if any complication happens with even with tenectase in these patients. So what I think what we are focusing is at present is fast, that is face, arm, speech, and time. But what we are doing now, but we should do very fast, that is vision, face, arm, speech, and time. So we should have a mnemonic like that, vision, fast, so that we should do more, make these understanding more to this public as well ophthalmologists, so that they should have, whenever there is vision as well as this other symptoms are there, they should reach in time to the proper neurologist or any intervention team which is available nearby. So vision, and in this posterior circulation stroke also, whenever these patients having posterior circulation stroke, I think posterior circulation stroke is a very tricky thing, where means many of the times it is missed out, that we are not having any warning signs for the public as well as for the ophthalmologist that these should patients reach on time, because they will have deficit of this semianopia or this blindness, all this over the period of lifetime. So fast I think should be the made mnemonic more frequently rather than fast in near future. I will just show another case. Actually, this is one of the interesting case of arthritic ischemic optic neuropathy. He is a 60-year-old male presented to ophthalm for acute onset left visual-sided visual impairment headache since 3 days, and visual acuity of hand movement up to 1 meter only. Fundus was showing chalky white disc in this patient, and BP was normal. Carotids 30%, stenosis bilaterally, as he was having very severe headache, so that, and his carotids were not that very significantly affected. I thought that it is more than this CRAO. They were treating as this non-arthritic ischemic optic neuropathy, or CRAO like thing. They were treating like that, ophthalmologist was. And after 15 days, patient still had headache, also had difficulty in chewing. There was so much difficulty in chewing that his jaw claudication was so severe. He could not chew his food for another 2-3 bites also. So that after that he will have severe pain and he will just drop out his food. On examination, there were bilateral temporal arteries, non-pulsatile and tender in mid part, which was shown in this diagram. There were both side temporal arteries were non-pulsatile. There was severe jaw claudication, and his ESR was around 76 and CRP was 26. And this was I have done this temporal artery sonography Doppler, and there is these anechogenic temporal arteries with no flow surrounded by mild hypoechogenicity was seen in this sonography, this Doppler of this temporal arteries. There is actually one halo sign which has been seen, which is quite sensitive and specific for the giant cell arteritis, which is not seen in this patient. If there is some flow is there, then we can see this halo sign. It is completely anechogenic, means there was no flow at all. So that this was shown as an anechogenic temporal artery. And this patient, after 15 days, beautifully responded to steroids, and after that he was put on mycophenolate, and his vision completely normalized within 3 weeks of onset of his symptom. So this was a giant cell arteritis which has been shown to have a good response to this steroids and mycophenolate. So that these cases should not be missed out, because these are very treatable cases. And I think showing the difference between this CRAO versus this giant cell arteritis, I have shown this case. And I again thank you for giving me the opportunity for share this case, and I would love to hear moderators' view on this case.
Dr. Meenakshi sir.
With sir's permission.
Yeah, please, Meenakshi, go ahead.
So that was a fantastic case. Totally thrilled. I mean, many of us do not get the opportunity. My many congratulations, Dr. Pramod.
Thank you.
And
Sir.
one intriguing point is that we should ask why we do not get to thrombolize these patients. Because most of us, even in big corporate centers, we don't have a separate ophthalmological department. For instance, in our own place, Madurai, we have a big ophthalmological institute, Aravind Hospital, which is some 2 kilometers away, 1.5 kilometers away from our hospital. So the patients have to reach there in time and then diagnose, because in a bigger the hospital setting, there'll be a protocol. People will take blood pressure and then take the Vishwan fundus. They go through the entire thing. And by the time they reach the consultant and diagnosis is made, all your time window has gone. And then the patient has to be recognized and then referred to us. So I think this is one of the main reasons why, as you've correctly said, we don't get patients enough for ophthalmological evaluation with CRAO. Probably this patient went to a single ophthalmologist who is practicing and not to a center, which is a big center for ophthalmology. And that's the reason why the pickup happened. This is what I feel. And then he also knew you, and that's why he could immediately do it. It happens at the personal level than from a center level. And that's one of the reasons probably why we do not have many studies on this disease. This is my own personal view, stand to correction by Dr. Paulson. So that's a very fantastic case, and the proof of the pudding is in the result. And you have shown an excellent improvement, and really we are awed by that. Otherwise, we all know CRAO has got a very terrible this one. In fact, I had an opportunity of doing this way back almost 11 years ago, 2009 or so. We had a patient whom we thrombolized. At the time, only Altiplace was there. And we didn't have such a good result. At the time we reviewed, the time window was longer. I do not remember the time. It was not this 4.5 hours window and all. We had a much longer time, but still discussed and we did it. But nothing happened to this patient. The improvement was not robust. And to tell you another case, recently, as much as 1 week ago, I've seen a patient with CRAO, visual loss complete, no improvement. They came to us because there was an involvement of the carotids in the form of more than 95% on the right side and 90% on the left side, whether to do an intervention further for preventing stroke. That's a doctor who came to us. So this tells us that many times it is missed even by a doctor. The husband is a doctor, wife is a doctor, and they missed CRAO and they did not come in time. So this is a very difficult diagnosis to make. I must really congratulate you. The question which you raised subsequently was whether to do imaging. I don't think you made any mistake in not imaging, because I remember one case which I presented to my teacher, Professor Dr. Talley. Sir was there in the rounds when I saw that patient, and I completely missed. There was a patient who had a very big stroke, and in my we didn't really pick it up. And then he said, "Did you see the fundus?" After seeing the patient was moribund, and I didn't see the fundus. He showed that there was a retinal pallor in that patient. At the time, he gave one important advice to us, that in exams, teachers like Paul sir may ask us questions when we are students. They can ask us questions like, is there any way 100% you can be sure that you can differentiate ischemia and hemorrhage clinically? The answer is no. You can have any number of things, for instance, CDRAT, stroke scale. So many scales have been evolved. After everything, before thrombolysis, you get a CT scan done. You have to exclude hemorrhage. The only clinical sign, 100% can say it is only ischemia when it is present and not hemorrhage, is when you have a retinal pallor. When that happens in a patient who's gotten a stroke in that same territory, it can never be hemorrhage. It was taught to me by Professor Dr. Talley sir. And I remember that when you are presenting this very excellent case. So I totally agree with you. Having the time constraints, if that patient had come to me, I think personally I would not have done any imaging before thrombolysis. I would have straight away told the family that I would like to thrombolyze without doing imaging, because I think it is only ischemia, and doing a CT scan would waste another 5 to 8 minutes of precious time. I would have told that, and I would have gone ahead in the same route as you are doing. And the next case, when it comes, I think that we should take the same route. This is the only thing which I would like to add. Regarding the thrombolysis, what to do intra-arterial and intravenous, we really told us. So only one question I have to ask Dr. Paul sir also. It is true that we will do a thrombolysis next case. But as sir was always saying, is it in the guideline and are we going to do it? That sir only can tell. Thank you very much, sir. I'll discuss this further next.
Yeah, Meenakshi, I think I completely agree with your comments and they are very, very correct. Can you hear me?
Yes, sir.
Yeah. No, am I audible? Am I audible?
Yes, sir. Very much audible.
Okay,
sir.
okay, very good, very good. You see, first of all, I must congratulate Pramod for an extremely important presentation. I mean, I'm so happy and thrilled. I'm only now looking for patients of CRAO to come to me so that I can summarize them. I mean, I'll tell you two reasons why it has not picked up. And I know it first time because my wife is an ophthalmologist. She's a retina specialist. Dr. Subhadra, she is a nationally acclaimed thing. And for 2-3 years, she has been after me to help her to thrombolyze her patients. But I only did not show any interest. And I represent all the neurologists. And finally, she also got discouraged. And, and she works in the best eye hospital of one of the best in our country. That's called LV Prasad Eye Institute. She's one of the directors of that. She also gave up. Now, why neurologists have not taken interest in this is because all our NINDS trials and all, they did not include CRAO patients. They did not. These CRAO trials are different. It's a parallel stream. So they still, the results are not out. They are still undergoing. See, the thrombolysis in brain trials are over now. TPA is a gone story now. It is Tenectase story. So we are quite advanced. But in ophthalmology, they are still doing these trials. So that is the reason. So there were some initially very fundamental questions we were asked. Should we give the same dose or not? Because eye is a very small thing. We should give a very small. Nobody was sure about it. And in fact, I remember at one time, it was said we should give 1/4 of the dose. But I think once I knew that this case we had to discuss, I also reviewed the literature. The beautiful thing is that we have to treat it exactly the way we treat the brain stroke. Same dose, same time window, but it has not yet come in guidelines. Why it has not come in guidelines? For the same reason I told you, because it has not, the neurologists have not done a trial on it. But I think it does not matter. I'm so convinced after looking the literature today and after hearing this presentation that the moment we get a CRAO, so what we should do is that now we have to, it is our job to popularize it among the ophthalmologists. We have to, create a ophthalmological awareness with our department. And then I think the way we have done public education for stroke, time is brain, same as our speaker said, time is vision. And I think there is absolutely no doubt about it. And IV is always better because, mechanical thrombectomy, to get that mechanical thrombectomy person and for him to go inside that such a retinal artery and all, it's a very difficult job. IV is very, very easy. And I think there is no difference between Tenectase and Alteplase because in principle, they are the same. If at all, Tenectase is better. So thank you very much for this presentation. It was a really eye-opener. And I think you should publish this because that will create more awareness. And we should all of, in our neurology circles, I think we should create awareness, maybe do some studies and raise awareness of this very important thing. Thank you very much.
Thank you, sir. Thank you.
Dr. Rahul, can you please also throw some light on this? Yeah.
I think it was an excellent presentation and CRAO thrombolysis really fascinating to look at the results we got. I think after this case was discussed in our Maharashtra Association of Neurology group also, and our neurologists have gone one step further. One of our colleague, Dr. Pradyumna Oak, has thrombolized a case of branch retinal artery occlusion also. So that's also in that particular case, he got wonderful results and vision got restored within less than 24 hours in that particular case. I think the major hurdle is to diagnose the condition in that window period. That is the most important hurdle. Otherwise, I think labyrinthine infarct or retinal artery infarcts are typical like stroke. The mechanism is similar and definitely thrombolysis should be considered for these cases. Only thing to diagnose these cases within the window period will be a bit difficult task.
But Dr. Rahul, I have one comment. Can I make one comment?
Yes, sir.
When we are within this window period is very important for eye also, as was shown to us by Pramod. because the retina also dies as the time goes. So we have to do everything not within 4.5 hours, but as soon as we can. I mean, within 1 hour, within 45 minutes if we can. Now, one of the things which our speaker told is that it should not be done in giant cell arthritis. Now, I was just thinking, I have not studied literature. I'm thinking on my feet. I'm telling you offhand that if you have to make that distinction, is it giant? Unless a patient is a known case of giant cell arthritis, then we have to do his ESR, we have to do his CRP, which is going to take at least 1 hour. So I am not sure whether we need to differentiate at that time for thrombolysis or not. I don't really know. I will have to read it unless you already have some comment on that. I thought that the moment you know that it's a retinal occlusion of any etiology, we can go ahead and thrombolyze, unless it's a contraindication. I don't know that really. I mean, you can probably.
Actually, this anterior ischemic optic neuropathy and CRAO, that has to be differentiated. In anterior ischemic optic neuropathy, you get optic disc edema initially. But
yes,
it doesn't happen with the CRAO because it's the optic nerve head is supplied by this short posterior ciliary arteries, not by this central retinal artery. So that central retinal artery gives pale retina initially, cherry red macula, and after that, after some time, you will get edema and something like that. But in anterior ischemic optic neuropathy, you will get first optic disc edema, and after that, you will get this pale retina and all these things. So it's a vice versa thing. So CRAO, it's very clear-cut diagnosis for ophthalmologists. They will see the pale retina, they will see the cherry red macula. They will definitely have a.
But why there is a contraindication to giant cell arthritis, posterior cerebral artery? Why posterior ciliary artery? Why it is contraindicated there?
Short posterior ciliary arteries. These are in branches. These 6 to 12 arteries are there.
Yes.
And it's more of a hypoperfusion like thing or atherosclerotic like thing.
So mechanism wise, it may not be.
It's not embolic. It's atherogenic. So that's why we don't thrombolyze these patients of.
So you think that clinically it may be possible to differentiate between them so that we save time? Yeah.
Yes,
okay. Good.
Pramod, one more question. One of the criticism for CRAO thrombolysis is the type of emboli these are. Most of the times these are cholesterol emboli.
Yeah.
And that's why how much thrombolysis will be working in that. That is what one of the criticism I have come across. What is your comment on that?
That is very difficult to cholesterol emboli. Definitely, they will not have a very good result with thrombolysis. But we don't know what kind of embolus he will have. So that we have to take that advantage of this will be some platelet-rich emboli or something like that. We don't know what kind of emboli this will be there. That we can't comment on that. It's very difficult to identify these emboli. So we have to just say the reason and we have to take a call for these patients.
Dr. Rahul, building on your point exactly, that was the thing in my mind, that this is a young patient with no comorbidities at all. And of course, I think no structural heart disease as such, so there's no question of anything to originate from the heart valves or any AF or anything reported. Now, only thing I could find was a dyslipidemia. Now, here the results have been excellent. So considering the results have been excellent, this looks less to be a cholesterol sort of a thrombus or something. It looks more of a blood or platelet rich clot or something. So what do you think could be the reason for this thrombus or emboli? I'm suspecting it to be an emboli and not what do you think would have been the reason for this occlusion or how it happened?
Many times we don't find the source also. So that this is called a ESUS. We can say that embolic stroke of uncertain significance. So this is an ESUS, which is where it is coming from, we don't know. So probably this dyslipidemia having some aortic arch, we didn't image, so that might have come from the aortic arch also. So we don't know where it has come from, but it must be some platelet-rich embolus rather than anything else.
Just thinking from the preventive point of view, because this patient had carotids are also clear and all. Right. I'm just thinking from the, and the other thing in my mind was to all the faculty is the window period. In cases of stroke, we say 4.5 hours because that's a cerebral tissue. Now, in case of retina, can we assume, sir, Meenakshi sir, I'm also, the question is to you as well. In case of retina, sir, can we assume the window period to be 4.5 hours exactly, or it might be shorter than that? I'm just thinking, may not be exactly the same. What do you have to say?
Can I answer that?
Yes, sir.
So the literature says that retina tolerates ischemia very poorly. That's why the prognosis is usually poor.
Yes.
Within 2 hours, much damage has happened. By around 4 hours, the damage is almost certain. That's why the prognosis is uniformly poor.
Absolutely, yes, sir.
However, that previous trials had not shown benefit because of one important reason. The trials included patients who were treated up to 24 hours. When you have such trials being included for analysis, naturally you are not going to see any great results. As Kalsar was teaching us, if we have patients well in time, we propose something and we do it quickly, I'm sure we should be able to produce results. Most of the results have not shown benefit because of that important reason that they included patients much beyond the thrombolytic window detected for stroke. That is one point. And regarding the approval for tenectase or altiplase as guided by FDA, I do not think that we are guided by FDA nor we have any obstacles for FDA. Our DCGA has approved tenectase, and I am strongly of the favor that we must use it. We should not worry about what the FDA says, but they don't regulate us. The third thing I would like to comment here.
Hello.
Sir.
Hi, welcome everyone.
Please, sir. Yeah.
The third thing is that regarding the photograph, that's a very interesting point, sir. So I am very happy you did not take the photograph of this patient, fundus photograph, because if we had a photograph, he would have no vision but only the photo. Because they acted very fast, they didn't want anything, and that's the reason why this fellow is actually seeing things and not seeing his own photo with the other eye. That's a great thing. I don't think we should.
I'm actually very much flabbergasted, sir. You know, in India, when you have to visit one doctor also, 1.5 hours may, the entire treatment happens is very rare to see. And here the patient touched to 2 doctors. I mean, the patient himself realized it's an emergency. He went to an ophthalmologist. Then luckily, he could meet. And all this could be done within 1.5 hours. Am I correct, Dr. Pramod? You had written 1.5 hours. Everything was completed. So that sounds like a dream journey for a patient to the better, health. So that's really applaudable.
This was friendship-based thrombolysis, trust and friendship. Otherwise, it would not be, because I have had the experience really. Because at that time, altiplase used to cost more than 50,000-60,000, and then you tell the patient there is no benefit. It's a difficult thing to do. I have done that. That's why I know what has happened. Zero benefit to that patient, completely zero. Although I do not know the time window in which I have thrombolized, no benefit at all. And the patient did have a beautiful photograph. Vision was not there. So, contrary to what you have said. That is the only thing I said. Only one suggestion, sir. Can I do a suggestion, sir?
Yes.
Sir, in the previous patient also, which I mentioned, the Doppler ultrasound sometimes is, operator variable. So I strongly suggest you go ahead and do a CT angio for this patient. Because by and large, when we say there is a retinal branch occlusion, it has to come from the main vessel. So my request, if you would consider, is to do a CT angiogram without any hesitation.
Yeah, sure.
And one last doubt I have to ask you. Sir was asking you about this posterior circulation, when posterior ciliary arteries, you said there are no hypoflow situation rather than an embolus or anything. Even in a hypoflow situation, once an infarct happens and the patient comes to the acute phase, what difference does it make for us? Anyway, there is a thrombogenic area. Anyway, some part is going for ischemia, and the patient has come to you in the time because the ischemia has happened. I still do not understand how the mechanism would really direct us in avoiding thrombolysis in the situation. That's a thought, that is all. You could just consider that.
Okay. So can we move to another case? Dr. Brahman, you have to say something or?
Our advantage, which I practice in my CT, is the time where there is travel time, there is no travel time, where we can go within 5 minutes to one place to another. So that is the biggest advantage of our place. So the thrombolysis is very easy. Suppose patients are at around 100 kilometers or 60-70 kilometers, they can reach within 1.5 hours to our center. So that is the biggest advantage of our place is there, which is not feasible in Pune, Mumbai, anywhere in Madurai also probably. So that I think
No.
advantage.
Madurai is possible. We are still a small city, sir. But I can tell you very much that a place near our place called Karaikudi, they thrombolize faster and they get results better than our results. Smaller the city, greater is the advantage. The trust is there.
Yes.
And bigger the hospital, lesser is the trust because of the extraordinary contribution of WhatsApp and Google. towards the understanding of patients as to how we are. Because
Plus,
they
there are
only
so many
fuel wrong things.
Sir, there are so many systems and processes if you see. So I agree with you. I think I totally, we have all at a personal level witnessed all this in our families. Yeah. So should we move to the second case, sir? We have a few cases in the second case and interesting cases. So I'll share the screen, Dr. Vedanayagam.
Yes. Good evening. Am I audible? Doctor, am I audible?
Yes, sir.
Yeah,
you're audible, sir.
Sir, good evening to all. And sir, special thanks to Dr. Meenakshi, sir. He is my teacher. I have got praise from him in Sign 2017. I think you may not know me, sir, but I will know you better. All over India, we will know you, sir, because of Sign meeting and you are conducting cases and also teaching classes, sir. And Kaul, sir, everybody we know, sir. Thank you, sir. I am practicing in Coimbatore, sir. So, quickly, I will go to the two cases. There is two systems involved in my cases. First case is bowel, and the next case is we'll see later. So, and the first case is fear on bowel makes brain to fast for 4.5 hours. Let us see what happens here. Next slide. Is a 48 is male. Is a known case of Crohn's disease. His last bleed was 6 months ago. He was treated with steroids, 6 units of blood transfusion, and methotrexate. He stopped his medication 30 days back. Now he presented with stroke in window. That is in 2.5 hours. And his score was 7. He has a functional weakness like dysphasia, facial weakness, and arm weakness. And there is no GI symptoms at present. At this point of time, will you thrombolize? This is the question arises in my mind because of in background, there is a Crohn's disease that was a massive bleed that was treated 6 months ago. And I was thinking that whether it is a disease flare or not, whether the disease flare associated with the stroke or not. So that's why I went to the reviews of literature and next slide. And how does, and let us see, how does a stroke occurs in Crohn's? There is 3 mechanisms that will cause a stroke in Crohn's. One is large vessel inflammation, which is evident by elevated factor 7 and 8. And the next is prothrombotic state. Because of B12 deficiency and hyperhomocystinemia, stroke will occur. And the third one is a slow flow in posterior circulation. These are the risk factors for Crohn's disease to get stroke. Next slide. And there are review of literature. Only 3 literatures I have got. And these literatures, next slide. And 3 cases of Crohn's disease has been reported. And 3 cases, out of 3 cases, 9 attacks of stroke has been encountered. That means each patient has 3 attacks. Totally 3 into 3, 9 stroke case has been reported. Out of 9, only 1 case has been thrombolized with altiplase. And there is no other details after that, whether they have had a bleed or not, whether they have GI complications or not, nothing was there. And second case, on the same patient, they underwent intra-arterial thrombolysis. Both cases has been reported in the literatures. Next. So this is the same literature which shows that intra-arterial thrombolysis in case of Crohn's disease. Next. So several studies have demonstrated that the active disease is associated with the increased risk of stroke. And sometimes acute ischemic strokes were not often associated with inflammatory bowel disease. In our case, hello, there is some background noises were there.
Yeah.
Dr.
Ankit, please mute everyone except Dr. Vedanayagam.
Yes. In our case, the factor 8 has been sent, but the reporting time is 24 hours. Now we are in urge whether to thrombolize or not. The next slide. Neka, the next slide. Doctor?
Give me a minute. My slides have got stuck. Give me a minute, please.
Yeah, yes. So it is a case of Crohn's disease with Crohn's disease presented with the stroke. Now I have discussed about the pros and cons of Crohn's disease during stroke. Is it opening?
Yeah, give me a minute. It's just.
Yeah, no issue. I will target it.
Yeah, I'll just.
So after reviewing literature, I have a fear whether to thrombolize or not. Because of thrombolysis, he may have again very massive GI bleed. That will horrible to the patient. And the
Yeah.
patient also known to our neurologist. He was in Chennai. So I talked with him also. And what we did means, and our aim is to revascularize the patient's stroke. So that's why we plan for thrombectomy. Next slide. Before that, we did, next slide, Dr. Nega.
Please excuse me. The slides are getting stuck repeatedly. I don't know why. Just
Okay.
I'll try once again.
No issue, no issue.
Or I'll not do full screen. I think full screen, in that it is getting repeatedly stuck.
Okay.
Yeah, I'll do it.
In the off screen, you can do it.
Yeah.
It is
Yeah.
okay. So what we did a CT brain to rule out stroke. There is no bleed or no hemorrhage. Sorry, no stroke, no infarct or a bleed. Next slide. And we want to confirm it with the MRA that shows there is a lacunar infarct in the perisylvanian area. And the next slide. And MRA shows there is no vasculitis symptoms, or there is no vasculitis, and there is no large vessel occlusion. Hence, we plan for medical therapy. I didn't send for thrombectomy. The next slide. So he was treated with ecosprin and intravenous steroids. And during discharge time, NIH score was improving. That was 3. And there is no flares for past 6 months. So this is our first case. And the learning point from this case is the next slide. And as it is rare, we need data and guidelines from the case series. And depends upon the clinical situation, we should get experts' opinion and review, and possible to make individual decisions. By luck, we didn't have large artery occlusion in this case. If they have large artery occlusion, we have to send the patient to thrombectomy in my nearest center. So that was the thing I was thinking at that time. But luckily, the patient has only lacunar infarct, so he saved. The next case. The second case is with the system involved is heart. The first case was ZIT, and the next case is heart. Let us see what was happening here. He's a 67 years male, non-diabetic hypertensive. He has a recent anterior MI that was 35 days ago. Now he planned for elective PTCA to the LAD. That is a left-handed descending artery has to be stenting has been planned. So during PTCA, patient developed acute right hemiplegia. That after dilating the balloon, he got a weakness on the right side. His score was 10, and also his patient was mute at the time. And this is angiogram shows there is a large left anterior descending artery which was showed occlusion at the origin. Next. Can you play this video?
Yeah.
Nega.
Yeah.
Yes. Yes. And this is in a cath lab. You can able to see that there is during first angio there is a LAD block, and you can now able to see the descending branch, that is LAD, that is stem occlusion. Now the balloon has started going inside that area. This time the patient was normal. After this dilatation, after flow, patient got stroke. His score was 10. So at this point of time, I was called to the cath lab where I see the case. He has a right dense hemiplegia and NIH score was 10. And will you thrombolize this case? That was my question at the time. So now I didn't thrombolize because he was on heparin infusion during that angiogram, and he was started on ticagrelor infusion, that is an antiplatelet that was given along with the heparin. So, and also a patient has anterior wall MI. So in view of cardiac wall rupture and then cerebral bleed due to heparin and ticagrelor, I didn't thrombolize. I was planned thrombectomy. So before that, we will review the literature for thrombectomy in concomitant MI. So next slide. And what guideline says, previously they said there is absolute contraindication for stroke thrombolysis in case of MI. Later they reviewed and changed the guidelines. In 2018 they say you can go with thrombolysis, and recently they added next slides. If the patient has features of cardiac rupture are risk factors for cardiac rupture, you should not thrombolyze. Otherwise, you can go ahead with the thrombolysis. The risk factors for cardiac ruptures are old age, female sex, previous, the large anterior MI, long time from that symptom onset to thrombolysis, and transmural extent. If it is a large anterior MI, you should not thrombolyze. And pericardial involvement is there, you should not thrombolyze. These are the cardiac risk factors. And in case of STEMI, in the first week, it is very difficult to have a thrombolysis in these cases because they may have cardiac rupture and also tamponade. So 60% chances of cardiac wall rupture is there in STEMI. In STEMI, you can go ahead with the thrombolysis. This is the guidelines given nowadays. Next. So these are the same guidelines they said. And conclusion from this study shows that is individualized. According to the risk factors for the cardiac rupture, you can go ahead with the thrombolysis. And alteplase or tenectase should not be avoided in eligible patients. That is a conclusion from the studies. Next slide. So what we did with patient is a CT brain. Immediately we took the CT brain. It was normal. There is no bleed or no infarct. Next slide. And patient was sent to the thrombectomy center. Next slide. With the femoral catheter in situ. This is anterior circulation. There is no large vessel occlusion. Next slide. It is a posterior circulation. There was no large vessel occlusion. Patient was again sent back to us, and he was treated with heparin and dual antiplatelets. During discharge, he was improving, and his score was 5, and he was treated with prophylactic with rivaroxaban and ecosprin. Next slide. From this case, the conclusion is, if it is an MI, anterior MI, we should be careful in the first week. If it is an STEMI, you can go ahead with the thrombolysis. So either preceding MI or concomitant MI, you can go ahead with the thrombolysis. Only the risk factor is cardiac wall rupture. That has to be tackled with the risk factor analysis. Otherwise, you can go ahead with the thrombolysis. Our aim is to revascularize. Whether the case is wherever the block, we have to revascularize. I think. Thank you. Next slide. Yeah, thank you to all.
Thank you. Thank you, Dr. Peter.
Yeah, thank you.
Yeah.
Sir, call, sir.
Yeah, can you hear me?
Yes.
Yes, sir.
I just, no, that's a great presentation. But about the first case, I wanted to know that what did you do in the first patient? That Crohn's disease?
Sir, we not thrombolize that case, sir, because of small lacunar impact and in the MRI, and there is no large vessel occlusion, and there is also no vasculitis. We go ahead with the medical management.
So yeah,
rather than thrombolysis.
I got it. In fact,
yes,
I remember many years ago when we were at the peak of thrombolysis enthusiasm, one of my friends, Dr. Shinish from Bombay, gave a lecture on when not to thrombolyze. So I think that could be the title of your talk also, when not to thrombolyze.
Okay.
So this is always a dilemma: should we thrombolyze or not? And I think both your cases have done well. But one of the other way of looking at it is that we always balance between, try to get a balance between risk and benefit. How much is the risk and how much is the benefit? And then share it with the patients and take a shared decision making. So for instance, if this patient of, let us say Crohn's disease patient, if you would thrombolyze him, you could potentially prevent the patient did well anyway, but you could, why we thrombolyze? We thrombolyze because we want to improve the outcome at 3 months. For the sake of that, you are taking a risk of a Crohn's bleed.
Yes,
but
sir.
the one logic is that the Crohn's bleed can be managed.
Yes.
Whereas if a stroke occurs, it may be irreversible. So
sure.
because this dilemma will occur tomorrow morning again, tomorrow afternoon again. That the and the patient may even be actively bleeding also. But even at that time also, sometimes some of the doctors, not you, some of the doctors may say, okay, I will still thrombolyze you. But what will happen? There will be gut bleeding. But I can handle gut bleeding. Or that you have to talk to the gastroenterologist or the surgical gastroenterologist or the interventionist. Can you handle it if this happens? And same is true about your cardiac also. If you see,
Yes, sir.
in the initial 1996, 2001, 2006, cardiac myocardial infarction was an absolute contraindication. Today, it's not absolute contraindication. Even they say you can thrombolize in you can thrombolize non-stem. You can thrombolize even stem also.
Yes, sir.
But what they say is that there is what happens is that the strength of the recommendations becomes little weak. From 1 it becomes 2A. From 2A it becomes 2B. But it never becomes C. It means it is never an absolute contraindication. They say that you can still thrombolize it, explain the risk to the patient. So I think my response to your thing is that I agree with you what you did at that time. I completely agree with you. Can you hear me?
Yes, sir. Yes, sir. I'm hearing
Yeah,
you.
yeah. But on the other side, there may be some doctors who may still take a chance and thrombolize them. They will also not be wrong. Now,
Sure,
in these cardiac things, this is a common bugbear. I get it all the time, that the patient is undergoing a coronary angiogram, or the patient is undergoing some procedure and he got a stroke. The only thing which I check at that time is his APTT, because they have received heparin. And if the APTT is less than 40, and I'm telling this after doing a lot of research and talking to a lot of colleagues of mine and all that thing, all the time we discuss.
Yes,
if
sir.
the APTT is less than 40, normal is 35, but if it is less than 40, you go ahead and shoot it. But if it is 50, 55, then I would withhold. Other than that, you can take your chance and you can give it. So so to cut the long story short, and I'm waiting for Meenakshi Subramanian and others to give their opinion. In both these cases, you may give or you may not give. Both decisions are okay after talking to the patient. But your decision also is okay. I mean, I see your point of view. I mean, don't think that it's easy for me to say that I would have given it. But so in that situation, I see yours. But both decisions are correct. To give it also okay. To not give it also okay. Like Shakespeare said, to be or not to be. But none of your patients were absolute contraindications. They were relative contraindications. The relative contraindications leads it to. But thank you. Great cases. I mean, I really enjoyed them. And I mean, I put myself in your position and I mean, probably I would do exactly what you did. Meenakshi, please, your points.
Thank you, sir. Sir, first, thanks for the nice words, Dr. Veda.
Sir,
you
thank
really
you.
truly stunned me. And that was because of the opportunity given by my teacher and professor, Dr. Lakshmi Narasimhan, sir, who is more than a brother to me. I should really thank him. He is like a God-sent brother for me. So thank you very much for the nice words, sir.
Thank you, sir.
Regarding this Crohn's disease, I think this case came up in the forum earlier also, correct, madam? One discussion about Crohn's disease came in this forum also. Yes, at that time also we reviewed literature. As sir was saying, there is no enough literature available for this because we can't get this. But theoretically speaking, with the hemorrhage risk on the cards, maybe a mechanical would have been optional, as you have correctly said. And if there is no large vessel occlusive disease, we may have fear of thrombolizing them because harm could be sometimes difficult for us to really manage. Regarding the other case, that's a really interesting case, really difficult case, I must say, because one, you have an anterior wall infarction, which will put you on the guard really. And secondly, to get a PTT time, because prothrombin time is much easier to do because you have a finger prick INR. Whereas for APTT, you will have to necessarily wait for our lab people to come, collect, go, give the results, which is not less than 40 minutes. It's going to be 40 minutes minimum. You can't get it before, irrespective of how much you howl at the people. It's not going to be possible. So we will be biting our nail and sitting and doing what is to be done. So mechanical would really take us, into the right pathway at that time, because at least for heparin use, APTT is useful. But most of the times our cardiologists would not be using heparin. They would be using low molecular weight heparin, and we will not know what to do at that time because we do not have anti-10 activity on board for our labs. And the second thing is that, as we are saying, they will be loading them with all those medications, this GP, 2B, 3A. And then they will be there, and they would have loaded them with clopidogrel 6 tablets and aspirin. All of them would increase enormously the chance of hemorrhage, that we would be afraid to do that. So most of us, we favor only this. Fortunately, we don't have many such patients, and the small instances we have been having, the patients were not willing or the cardiologists were not willing. So that has solved most of our problems and we are safe in this. But it's a real challenge I think we must be able to take. The one reason thrombolysis can be tried, but one interesting we must keep in mind is that the thrombus may come from the catheter. You are showing the catheter.
Yes, sir.
A thrombogenic material
Give me
can
2
come
minutes.
and
I
it
know.
can go up.
2 minutes.
If it goes up, it is going to come out like anything with your thrombolysis. But many of these people will have calcific plaques as well. So we have to ask the cardiologist, especially it will be there in the aortic arch. If there is a calcific plaque and that gets dislodged and goes up, uniformly it is going to be unresponsive to IV thrombolysis. So that is one caveat we'll have again for IV thrombolysis, but it is difficult to say. I will share one experience of my own friend who's a brilliant cardiologist after Dr. Rahul gives his comments also. I have an anecdote to also share here about this thrombolysis in the cath lab.
I think both were excellent but complicated cases, and to make a decision in such rare scenarios is really a difficult task. The first case of Crohn's disease, and considering the risk of Crohn's associated bleed, whether to thrombolize or not to thrombolize is definitely a difficult decision. But I think in both ways, as Dr. Kaul sir said, can be a correct decision. But rightly so, when the case is rare, the experience about managing stroke in that particular case, if we are not aware, I think not to be very aggressive in that term will be my policy in such kind of cases. Second case regarding myocardial infarction related thing, when the patient was undergoing coronary angioplasty, and that time he had developed a stroke. Again, that time, again, a complicated situation. Patient had already received heparin, ticagrelol, or your G2B receptor antagonist also. In that situation, again, the risk of bleeding is very high and mechanical thrombectomy becomes a little better option as far as that situation is concerned. But both are difficult situations. And as earlier we have said, there are less and less contraindications for thrombolysis nowadays. But I think in such situations, you have to take individualized decisions at that particular point, considering the relatives also, explaining them the risk of bleeding. That is all becomes very important. So there are multiple factors while taking decision of thrombolysis in such kind of cases.
Thank you.
With the permission of the chair, can I share one good anecdote in a similar vein, madam? Sir, can I share,
Yes.
sir? How's that?
Yes, sir.
Yeah, go ahead, sir.
There is one cardiologist friend of mine who is my guru, my classmate. His name is Dr. B.R.J. Kannan. He is well known in cardiac circles. Cardiologists would definitely know him. Brilliant person. So way back in 2006 or 7, I think, he had a patient. At the time we were, going behind altiplays and we were making our, thumping fist, give us cases and all those things. From the cath lab, he called me, said during his procedure for a mitral disease, the patient developed stroke. What is to be done? So I immediately said that we had to give only altiplays within 3 hours is the window. At the time, ECAS 3 was not published. It was only 3-hour window. Said we had to do it. And their hospital, they did not have altiplays. So he called me and said, now you send a person to me. I will immediately see that the drug reaches you and you can pay later. That was one of those CM scheme patients, no money. If at all, doctor has to pay, and he didn't have this one. So he said, are you sure that I cannot use any other thrombolytic agent? I said, there is no approval for any thrombolysis. So he said, can I use streptokinase? I said, no, you cannot use streptokinase because the ASK trial miserably failed. Australian streptokinase trial miserably failed, and you cannot use it. And I said, immediately shift the patient, stop, get a CT scan, and we'll do it. So I didn't receive a call for him for at least about 1 to 2 hours. And then he called me. The patient with a dense hemiplegia was totally normal. No CT scan done. He decided, he just spoke with the family and he gave streptokinase, intra-arterial. Spot normal. And they could only afford a CT scan after that. The CT scan was normal. Nobody knows whether he had a stroke or not. The proof is that the patient had a very dense hemiplegia, and that person is a clinically very, very strong people. I mean, if in any of your cities, you ask your cardiologist and tell the name Dr. B.R.J. Kannan, They would vouch for him. They all knew him. So you cannot miss on that. And this person has said there was a dense hemiplegia, streptokinase, totally normal, absolutely normal. I said you can publish this. With what data? You can publish nothing. So this is only an anecdote I can share. So I think sometimes bravery works as
No,
Paul
patient
Sanders
became totally normal after streptokinase.
Totally normal, sir. Absolutely normal, sir. Zero weakness.
Meenakshi, can I make a point?
Yes, sir. I do not know what has happened. Yes, sir. I'm waiting, sir.
No, it's a great thing which you said. This will never come in clinical trials. It's an individual thing, and it's a great we can learn from it. Now the point is that this is always a bugbear, and we often get calls that, as I told earlier also, that during the CATH procedure somebody gets a stroke. And we also used to think a lot about it, worry about it. But if you go to the guidelines, I'm just telling you guidelines of 2021 or 2019 upgraded, they are no longer contraindications. That cardiac rupture, we used to worry so much about it. And I'm sure cardiac rupture exists, but it is not that common as we used to think about it. And particularly in the first 1 or 2 days, it's not that common. Eventually, it may be, but I don't know, is there any series on cardiac rupture as such? I have talked to cardiologists about it and all. But still, there is a risk, but not that much as we used to think before. As I told you, if you look at the guidelines, they will say if it's a stem 1, if it is a day 3, you can still give it, but the recommendation becomes weaker. It becomes 2B. But in nowhere the recommendation is C in the red. Nowhere it's the absolute contraindication. So which means that we have to take the risk, and if we feel like taking the risk, we can take the risk. It's not an absolute contraindication, but it is. But the risk is there. Some risk is there. Yeah.
These patient received actually streptokinase, sir.
Yes. Yeah, your patient received streptokinase, which is
that was tremendous.
The good thing is that but the good thing is that your patients did well.
Yes, sir. Totally normal. So when scot-free and did not afford to even do a CT scan. He got a CT scan telling his hospital free of cost, normal. Yeah. Intra-arterial streptokinase in the cath lab, absolutely normal, dense weakness. I mean, no, but this encouraged us, sir. Sir, I had subsequently a case in 2012, 2009 or 10, 12, not 10 or 10, or I do not know the year. At the time, Dr. Peri Karpan was with us. We had a patient who had a mitral valve disease, and then the patient was about to be discharged after 2 days, second day procedure, developed a stroke in the hospital. And the cardiologist called me, and we rushed, and we had a protocol. We took the patient. I spoke with the family, and I told them that we had to do a thrombolysis, but procedure, at the time major procedure, whether it was a major procedure, minor procedure, we did not know. So I offered only intra-arterial, at the mechanical had not come. So we offered intra-arterial drug, and altiplase was very expensive. We took it from your other colleagues. They gave us free. Sir?
You gave urokinase?
No, sir. The same Tenectase from their Emcure only. Okay. The other product. We spoke with them. They gave us a free sample. And we gave an intra-arterial Tenectase to that patient. And the patient became completely normal. NHS only 1. And the cardiologist, when we came out, he says, SMS, I think you have treated a TIA. I told him, sir, the patient had weakness for 2 hours. You are saying that, and you are telling me it's a TIA. And why did the MRI show this infarct? So we saw the infarct on the MRI. And prove that, the next day, 24 hours later, we repeated the MRI. The patient was clinically totally normal on the second day. The MRI showed a larger infarct. And we published that case. When we published that case, the reviewer asked us, why is it that the patient has got a larger infarct after 24 hours? I said, I do not know. You have to tell me. And they published it. This is their intra-arterial Tenectase in a patient with mitral disease.
Great, very good.
So sometimes we do not know. We have to be bold. As sir said, no, but that case really stimulated us to do that. We will go ahead and do it, tell whatever, but the patient has to understand. And we always take a video consent. Once you take a video consent, everything is clear. Otherwise, consent is not accepted.
Thank you so much for your nice account and your
Thank you for
sharing
the
your experience.
Sir.
Yeah. Okay, Neha, I think we are over the time.
Yes, sir. The interesting discussion is going on, so I'm also
Both
enjoying.
speakers did a great job,
Yeah,
including
absolutely.
moderators, including
Yes.
you. Thank you so much.
Thank you so much. Thank you, sir. And I once again thank you for being with us here today, Dr. Meenakshi Sundaram, sir, for your excellent deliberation, moderation, and giving us some anecdotal evidences from your own clinical experience. Dr. Rahul Bhaviskar, sir, for bringing some excellent points to the table, and our key speakers, Dr. Pramod and Dr. Veda Naigam, for bringing some excellent out of the world cases. And that's what is the beauty of this forum. That's what we gather each month here for, to discuss some really unique cases and enlighten others with the, this is a scientific feast. And we have about 300 and 400 plus neurologists watching us right now live. So that's an excellent, I thank you all for this achievement. And we'll meet again, once again, next month for another excellent cases. Until then, I would stay safe and stay healthy, all of you. And goodbye. Good night to all of you.
Thank you. Thank you.